For you youths out there, this is a special treat to have Professor George Ojemann talking to us today, lecturing to us today. Dr. Ojemann, for those of you that may have not been born or have been dead for the last several decades, George Ojemann is perhaps the finest surgical neuroscientist of our time. So when I was a young boy and training in Boston, they referred to George Ojemann as Bob's younger brother, okay? When I got here, no one knew who Bob Ojemann was because everything was about George Ojemann. But having said that, George did seminal work on brain mapping and understanding how the brain works. No more needs to be said. All you need to do is read his papers. So it's a special treat that we're getting our Professor Emeriti to lecture to us because you're going to really see some incredible thinking. And so without further ado, George, thank you.
Thank you for that excessively laudatory introduction. Nowadays, when I'm asked to give a talk, it's usually about the history of some field, as though having participated in a little bit of it, I might have some unique insights. So it is with the first international brain mapping course that's going to be put on just before the forthcoming AANS meeting in Chicago at the end of April. I was asked to make some remarks about the history of electrical stimulation mapping. Now, this is going to be a dinner talk, and as such, it's probably appropriate that we start with a culinary item. This, by the way, is the housekeeping, all the disclosures and my primary sources for most of the pictures that I will show, except those in the specifically cited articles. Because the history of electrical stimulation mapping can be reasonably thought to begin with this experiment, which was performed by Luigi Galvani in 1786. He suspended a frog's leg, that's the culinary item, on copper hooks on an iron frame, and attached a wire to the frame, and lo and behold, touched the frog's leg and jumped. That is the observation. His conclusion from that was that there was animal electricity. His then contemporary across the Po Valley at the University of Pavia, Galvani was in Bologna, looked at this same experiment and said, oh no, it isn't. It's electrochemical electricity. And because he had two different metals on his books and frames. And this controversy lasted for approximately half a century. The results of it, however, eventually were the development of electrical neurophysiology, though it took about a half a century for that until the observations of Dubois-Reymond in the late 1840s, and the development of electrochemical electricity in storage batteries and electric cars. I should add that once the controversy started, each one of them then did the definitive experiment. Galvani got rid of the metals and showed he still had electricity. And Volta got rid of the animal and showed that he still had electricity. And then it all evolved into all these things over time. Now, there were precursors. The first half of the 1700s was a very lively time for examining electricity, mostly what we now call static electricity. And as one of those investigations was the application of electrical stimulation to the cortex of the decapitated heads of criminals. The result of which was something so gross that the spectators all fled, that it was eventually banned in Prussia, right at the turn of the century. So this is the first of what you will see are several skeletons in the ancestral closet of stimulation mapping. It did result in one meaningful observation. One of the people who stimulated the decapitating heads also stimulated through the dura, through a trephine in an awake patient, and established that the dura, at least at that point, was insensitive. But the result of all this was that for the first half of the 1800s, up until about 1860, there was very little more done with electrical stimulation of the brain, or for that matter, of the nervous system. It was, however, a period of the flowering of neuroanatomy, and so it was thought to be the time, at least, of the first accurate description and naming of the cortical gyri. Now, the cortical gyri had been around and known for a long time, but if you look at the Vesalius plates or any of the subsequent ones, it sort of looks like a cauliflower head. But this man, Luigi Rolando, was the person who described in detail the cortical gyri, or at least so it was thought, and he was given that honor. Although it turns out that about 30 years before, they had been identified by another person, Vic de Jure, whose contribution simply got lost because his printer forgot to include the plate that showed that in the later editions of his book. But as to function at that time, the prevailing view was that there was no cortical localization. The cortex was involved in the common sense. It didn't have a motor function, it didn't have any localization. And it wasn't just cortex as we think of it. This was the whole, basically, cerebral hemispheres. It was thought that what functional localization there was subcortical nuclei. And I suppose that's partly a result of the fact that the observations were often made on avians, and where, of course, it is the subcortical nuclei that have the function. Now, the other thing that happened in the first half of the 1800s was the concept of cortical localization appeared. And it was Franz Joseph Gall who was responsible for this. Gall's observations were first that the facilities of the mind were localized within the gray matter, not just the entire hemisphere, but in the gray matter, and that they were separately localized. Now, the trouble was that what the functions of the mind that Gall was interested in weren't quite the ones that we think about with stimulation mapping now. He didn't care at all about motor function or language. He was interested in something real, like moral religious sentiment, or hope, or justice, or sublimity, or acquisitiveness. And furthermore, he sort of reasoned that if you were particularly good at this, it would be like a muscle, and you would have a bigger area of brain for that. And that once this happened, of course, this would be reflected in the overlying skull. And this led, with his colleague Spurzheimer, to the development of what is known as phrenology. And phrenology, rather rapidly, took hold of the public mind. It became a whole rage in Victorian England and the United States. And it was taken over very quickly by quacks and charlatans, exploited. Now, in Gall's phrenologic map, there is no place for language and motor function at all. In a somewhat later one, which is what I've depicted here, they did find a place for language. There's no evidence of motor function here at all. And it's right there, coming right out of the organ. And it was rather to my surprise that I discovered that this is probably the only thing on this whole phrenologic map which is actually based on observations. This is based on the one case report that had been made up to that time of a pathologic correlation between a language deficit and a brain lesion. And it's a report by someone named Bouliot in 1827, and unfortunately that patient had an orbital frontal tumor. And so it was sort of logical that you would put language coming out of the orbit with your the phrenologic sign. So it wasn't really until the last half of the 1800s that stimulation mapping was resurrected. And it was really the observations of Hewlings-Jackson in the 1860s, who wasn't a localizationist at all. He subscribed to the general view that there wasn't localized function, but he was a very careful observer of patients. And in observing focal motor seizure progression, he actually worked out the homunculus of motor cortex and became convinced of that localization. And its result over the next decade was a whole series of experimental studies that really were the ones that worked out the motor map. Part of the reason stimulation also revived in this era is that there were finally techniques to control the current levels. One of the troubles with the earlier stimulation is that they didn't have techniques to control the levels, and they had the effects they got were all confounded. That is, they got current spread to the external muscles of the scalp and elsewhere in the body, as well as effects directly on the nervous system, because they ended up using quite large currents. At any rate, Jackson inferred the motor localization from the seizures in humans. This stimulated Edvard Hitzig and his colleague Frisch to study the dog cortex stimulation, and were able to evoke localized motor movements. And this was followed up by the work of David Ferrier using much smaller currents, who stimulated motor cortex and worked out detailed localization. So by the middle 1870s, this was pretty well established in animals, although Ferrier's work was much criticized by some because they thought it was just current spread to these subcortical nuclei that had all the localized function. So even then, that view was still persisting. Now, rather quickly, neurosurgeons jumped in to the scene. And this is the first stimulation of an alive human brain performed by Robert Bartholow in 1874. And what Dr. Bartholow did was he had a patient who had a lesion which had eroded through the skull and scalp and left the brain exposed. It was an epithelioid tumor. That was how it was described. And he took a probe and he stuck it through this opening, and he turned on the current, and he got motor movements on the opposite side of the body. And then he stuck it a little more posteriorly, and he got painful, intense sensations on the opposite side of the body. And then he repeated the first one, and he got a motor seizure, starting with focal motor signs. Unfortunately, the patient died about 3 days later. And the public did not view this as a particularly positive experiment. And we have now the third skeleton in the closet of stimulation mapping. The first one, of course, being the efforts to stimulate the decapitated heads, the second, phrenology, and now the third, our first efforts at applying this to neurosurgery. However, about the same time, Victor Horsley performed the first resection, cortical resection, for epilepsy in a case which Jackson had localized the seizures into motor cortex. And there now was a reason to apply stimulation mapping from the animal motor work to the humans And in fact, over the next couple of decades, a large number of prominent neurosurgeons jumped into stimulation mapping of the motor system as part of their treatment of focal motor epilepsy. One of them was Harvey Cushing. Cushing paper is in 1909 in Brain. He has been touted at least as having reported the first case of evoked sensation from human cortex. I'm not sure that's true. His report in Brain is of two cases in which he stimulated the sensory cortex and motor and sensory cortex. Motor effects up here, sensory here. His goal was to evoke the patient's seizures, and he did so here and performed a little focal resection with no real benefit to the patient. But at least he had established the sensory responses here in the little finger and hand here, a feeling of warmth down more where we expect maybe face sensory things. A little bibliographic aside here. First, that in this era before, the internet and electronic libraries, the way you got copies of papers was to fill out a penny postcard and send it off to the author, and they would then send you a reprint. And usually on the reprint, they write a little something in the way of a dedication. And it happens that the copy of this paper that I inherited from Dr. Ward is the one which Cushing had sent to Penfield in his little dedication. For those of you who write papers also, you realize that, of course, in those days, 2 cases was quite enough to get a publication in Brain. Now, the motor mapping then became a piece of the neurosurgical armamentarium, at least in those people who addressed the problems of refractory epilepsy. And the person who probably developed that the most was Otfried Förster, a German neurosurgeon, who had extensive experience with the injuries during World War I, where the shrapnel damage to motor cortex was the cause of the focal seizure abnormalities. And this is a summary of his experience with stimulation. The way he used stimulation is he tried to evoke seizure onset. So he's using big currents. And he's using it with a technique that really is just trying to produce the aura. And these are the areas where he had the effects. You can see there's many motor effects here, sensory effects here, all with the appropriate homunculi, a little bit from primary auditory cortex and temporal lobe, a little bit visually, although I don't think he had much experience with that. And some from up here around supplementary motor area. And then all the rest of this, all of these readings, he didn't evoke anything with his stimulation, even these relatively large currents. Wilder Penfield studied with him. In fact, this paper is a joint effort of theirs, which summarized Förster's activities. But it really was Penfield then who expanded the stimulation effects beyond these primary cortices that you saw there into a technique for mapping association cortex and specifically language. Penfield's two contributions were first the application of EEG diagnostic work to these patients, so that you now have identified a new group. Before that, it was all people with focal motor or focal Rolandic epilepsy. Now it was people who had temporal lobe epilepsy and partial complex seizures that were identified on EEG criteria. And then the second was his observation in the middle 40s, that if you had the patient actively engage in a language task, you could identify sites where it was interfered with by stimulation. And this is his series of patients with all of the sites where he got anomic responses. And of course, it's evidence that yes, the Broca's area was important, and somewhere Wernicke's area was important, but there was a very wide distribution here. Some really too far anterior and too far superior and too far posterior than the traditional Broca-Wernicke models that have been developed from studies of brain lesion effects on language. And then Penfield, when he summarized all of this in the Penfield and Roberts book, made this statement. Curiously enough, now that we have carried out this test, that is mapping during speech cortex, some hundreds of times, we find it necessary to use it much less frequently. This is because of our growing ability to predict speech area limits. So even though his summary had shown that this extended beyond the limits that were anatomically accepted as language cortex, he retreated to planning his operations anatomically. And those limits are shown, that he thought were the limits, are shown here in this figure from his book. And the result of this was that this was little used by his trainees. Dr. Ward would use stimulation to identify motor cortex. He would usually have the patient count and see if he got counting arrest in what he thought was the dominant hemisphere from inferior frontal cortex, and that was it. And he didn't otherwise use it in any way to plan his surgery. Now, Penfield in his book didn't show any individual case maps, individual maps of an individual patient. He just showed his summaries. He describes a few patients in the book, and you get the impression that sometimes he found very focal areas in a few of these patients and areas between them where he didn't find naming changes, but he really didn't look at the individual subject maps. And when we got, I and my colleagues got interested in cortical stimulation in the context of epilepsy surgery, one of the things we found is that there was quite a little bit of variance in the individual subject maps, but in any given subject, the areas where we could interfere with naming were often quite focal. Here's an example in the inferior frontal area and temporal, and not of all these other sites. And here's another example. Here we have a site that's way too far forward by anatomic criteria, which generally said that anything in front of central sulcus is pretty safe in a temporal lobe resection. And we have a somewhat larger area here, but here we've got a patient in whom we can't find anything much posteriorly, but we have a large frontal representation. Here's exactly the reverse, a large posterior representation and nothing particularly frontally. Again, somebody with frontal representation and superior parietal representation, but not down in the temporal lobe. So a whole variation but in an individual subject focal, but very variable across the population. And then we did something else that Penfield hadn't bothered to do, which was to show that this really predicted postoperative function. The data here on the left is from epilepsy surgery, temporal resections, and what we found is that when we gave these patients a quite sensitive aphasia battery a month post-op, that the sites, some of the patients, when we had gotten close to a stimulation mapping site with where we gotten language interference, did have a subtle but definite increase in their errors post-operatively. And when we hadn't gotten close to a stimulation site, they didn't. There was no relation to their preoperative verbal abilities, the extent of the resection, or the degree of seizure control. It was how close you got to the stimulation mapping site. And then later we got the same sort of data for stimulation mapping with tumors, where we tended to be more aggressive. Here, this is simply, this was the sensitive battery. This is a clinically detectable language disturbance. And if we got within 7 millimeters, we had a fairly significant percentage of people with a disturbance initially, and it got better. And if we got closer than 7 millimeters, we had some permanent deficits. Again, it was the relation to the stimulation mapping site. So it was telling us something about that was important to our planning the operations, and it was to avoid the language disturbance, and it was in different places in different patients. And if you looked across all the patients, you got this sort of a map with this substantial individual variability. Here is the number of people, patients where we had the number of samples actually that we had in this 117 patient series of all left dominant patients. And these were the percentage of those patients with the sites of language disturbance that we evoked. Here in the inferior frontal area, a pretty high percentage, but not 100%. Here, back in what should be Wernicke's area, we don't do any better than about a third of any one location, and indeed, in the whole superior temporal gyrus here, there's only about 2/3 of the patients that had any site anywhere that we could find. So this really is the basis for stimulation mapping. And what it's let us do is applied to the clinical setting. And what it's let us do is an operation like this. Here's the sylvian fissure, the nose is up here, the ear is over here. This is, of course, the surgical view, motor cortex, sensory cortex, a dysplastic focus here, back in what should be the middle of Wernicke's area, but we identify the language sites with stimulation and plan our resection around them, and end up with a patient who is seizure-free and does not have a clinical deficit. Now, we were interested, of course, in the neurobiology of language, and so we applied, we evaluated this patient series of 117 cases for their any relation of some of these different patterns to performance, and we had a verbal IQ as a measure for that in all of these patients, and found some differences with larger total language areas in the people with lower verbal IQs, and particularly with specific superior temporal gyrus involvement. And we found some gender differences. We had a small group of people with only frontal language sites, and they tended to be female, significantly so. And we had a small group of males with only parietal language sites, and they tended to be, or we had patients with only parietal language sites, and they tended to be male. And we found eventually, when we got a large enough series of young patients, that we had fewer language sites in the younger patients, with those less than 9 having fewer sites than those between 9 and 16, who in turn had fewer sites than those over 16. And with our mapping going down to as low, the youngest patient that I ever mapped was 3.5 years old. Now, all of this had been developed in the context of epilepsy surgery. And it really wasn't until about 1990 that this was disseminated to oncologic neurosurgeons. And that came about with the fortuitous association of Mitch Berger joining our faculty and being interested in this and spending a couple of years, the two of us working together, until he went forth and popularized this as a technique to do more extensive resections with tumors and still preserve language function. Now, in the remaining few minutes, I want to provide a little historical background for what are some of the contemporary issues in electrical stimulation mapping of language. I'm going to talk about 4 briefly. Its relation to other modalities for localization, the question of subcortical pathways, the question of plasticity, and the issue of what functions to map, all of which are things that are still controversial in this area. The first issue in terms of relation to modalities for localization is, do you have to bother with mapping at all, or can you get away with just keeping your resection based in the area of pathologic abnormality? Because it's certainly been said that all you had to do was stay in the gross tumor. And this is from one of 2 papers that were published almost simultaneously. They're only a couple of months apart. One from us and one from Washington University in St. Louis. And their papers generally confused because there are too many Washingtons, too many universities, and too many Ojemanns in the attribution of these papers. But what they show quite clearly, and this is an example, that there can be, in the middle of grossly abnormal intrinsic tumors, you can have intact function. This was the limit of the tumor based on intraoperative ultrasound, and here is the language function, and our resection was limited by that, and then it had both series had similar cases. Rather surprisingly, it also applies to dysplasias. One would think that dysplasia, which is after all something that's supposed to occur in utero, basically, you would think that this would alter function and push function off some other place, but that is not true. And this is an example of an open lift schizencephaly here of this patient, and this was still the dominant hemisphere, and here is the mapping. Here's the schizencephaly. Here's one aspect, a set of language functions. Here's another, and these oral facial motor related functions, these related to anomic changes with the epileptic focus right smack in the middle of all this, which greatly limited what we could do for this patient. Blood is an important, these are and fairly frequent, the encountered observation that even in the presence of dysplasia, function does not necessarily move to some other location of the cortex. Now, there are other techniques for investigating brain function in humans. But if you look across all of them, they can be classed into sort of 2 general groups. There are those which relate a brain region to a particular function. When that brain region is inactive, that function fails. And so at least that point in time, those are essential. And these are of course, the classic lesions. What we've gotten with electrical stimulation mapping, which presumably results in depolarization blockade. And then the intraoperative, intravascular neuroparalytic drugs. And then the other techniques that are popular are all techniques which provide a different kind of information. They show where an area is participating in a function, but not necessarily whether it's crucial for it. And that includes the techniques that involve the metabolic correlates, oxygen extraction and blood flow, and in functional neuroimaging and PET imaging, the neuronal swelling that's involved in the optical imaging technique, and then all the electrophysiologic correlates, the corticogram, the microelectrode recording, the scalp EEG. And it's simply an empirical question whether any of these correlates will match this, which is of course what the surgeon wants to know, because you're planning your operation. You don't want to leave a deficit. Well, this is the literature on the relation to FMR. We only did a very small study here that I've not included, but there's some pretty good ones in the literature, and they've all shown pretty well that as far as language localization is concerned, with FMR, there have been major discrepancies, and the consensus, at least a few years ago, was that the fMRI alone had not been shown to provide the localization crucial language areas that you needed to, in order to plan the operation. We looked at the relation of the electrocardiogram to our sites for stimulation mapping, and it was associated with interference in naming. And what we found was that we were looking for corticographic changes at naming sites with evoked naming changes during a naming task, and we found frontal slow potentials and temporal desynchronization. Now, unfortunately, in those days, we chopped off the EEG at 20 hertz in the operating room. We didn't look at higher frequencies. So what we had to use in order to quantitate this was just the disappearance of the alpha frequency, the 7 to 12 hertz frequency, when it came to quantitating the focal desynchronization. Here's that slow potential. Here's the local desynchronization change you can see at the naming sites during the naming task. This was an overt. This was done silently. This was done overtly naming. And you can see that at least this potential is also present with overt naming, which might be a sign of silent speech, internal silent speech. At any rate, we can show the quantitative change here in the loss of this. More recently, people have thought that there is activity at around 70 hertz that reflects the language function. But it has not yet been established that that shows the same localization that you get with stimulation mapping, and that it predicts the effects of surgery. That's still an empirical matter for investigation. Then there's the question of subcortical language representation. And rather surprisingly, surface stimulation predicts the effects of a resection that includes buried cortex. And if one resects the adjacent gyrus, you find that the surface language sites rarely extend down into the sulci. You can go back and forth between sites on the surface that evoke interference and sites on the bank down at the sulcus that don't change it at all. And it's adequate, this surface stimulation, to predict the effects of a resection that at least in temporal lobe and inferior frontal lobe, extend down deeply into the white matter, providing you don't undercut the surface areas. And so it suggests that the subcortical connections are at very vertical ones rather than ones that extend far anterior and posteriorly within the frontal and temporal cortex. This has been an area of active interest, largely because of DTI and the efforts to identify these different pathways. And most of that's focused on the long anterior-posterior bundles, the superior and inferior longitudinal fasciculi. On the other hand, Penfield, in his book, talks a great deal about the role of the thalamocortical connections. Those have been known for a long time. The only problem in Penfield's book is that he had no evidence at all that the thalamus was actually involved in language. So that was all the hypothetical end, but he could certainly see the connections coming out with his dissections. About a decade after his book, we applied the stimulation mapping technique to the thalamus in the course of thalamotomies, and were able to show the thalamic representation of language, which you can see over here in the left and not the right thalamus. So our subcortical connections include not only the anterior-posterior longitudinal fasciculi, but the thalamocortical ones. And now here's some more, because in the course of some of those cases of thalamic stimulation, we were using multi-contact electrodes coming in from a posterior approach. We had electrodes that went through the white matter just lateral to the splenium, and here you see that we evoked interference of naming from both right and left brain, even though once we got the thalamus, it was only in the left brain. Presumably these are white matter pathways that carry information back and forth between the language cortex here and say the visual information coming in from the right side, which of course are perhaps is the basis for the language deficits that come with posterior cerebral infarctions that produce a visual field loss, so that no visual information gets to the left brain. That which intact field in the right brain simply can't get across. Now, what about plasticity? That's been another lively area in the current field of stimulation mapping. Hugh Dufoux and his colleagues very much believe that you can do a cortical resection on a tumor and then come back later on, and the language area that interfered, that you identified on your first operation, will have moved so that you can now do a further larger resection. That certainly has not been my experience with the epilepsy population. In that, and here is an example. This is a patient with the very focal patterns here that we operated on in 1983. Her seizures recurred a decade after that. We remapped her with a grid in 1996, and everything is exactly the same, using the cortical veins as your fiducials. Nothing has moved at all. And we looked at some 22 adult epilepsy patients with a follow-up between the two operations of a mean of about 8 years, and a few cases more than 20 years between them. And again, matched the cortical veins. There, of course, had been a temporal resection between the two that had failed eventually. And in the portion of cortex that was sampled in both operations, almost all the patients had site related to language within 1.5 centimeters of the site that was first related to language, and half of them had it within 1 centimeter, which was probably the limit of resolution of that study. So that it really didn't look as though there was any plasticity in this adult cortex, at least in the epilepsy patients. The tumor patients may be different. There is some plasticity related to your experience with the task. You remember that we found that in the patients who weren't very good at our naming task, even though their baseline performance was not effective, but their general verbal function wasn't very good. We had bigger areas involved with from which we could evoke naming changes. But here we had using this Washington University task where they give you a noun and a stem, and you have to generate a verb for that. And this is a task that we had some patients, some lists of which the patient had practiced, and other lists that were novel. And when we mapped a few sites in these patients, here's where we interfered with little triangles with the novel task, and here's the same patients with the practice task, and you can see it is shrunk. So that experience probably results in a smaller pool of neurons being necessary for the task. All right, what functions to map? Well, this was sort of brought home to me recently when through social media I was put in contact with a patient that I had operated on in the 1980s, who basically said that he wanted to thank me for making him seizure-free, that it had made a real difference in his life, and it had been a really good trade for the fact that he couldn't read now. And now, whether he actually can't read or it's just so slow that he doesn't like to do it, I don't know. But it raises the question as to whether the mapping, which in his case was all mapping with object naming, provides you all the information you need to plan the resection. And here are some cases where we had looked at the interference effects on sentence reading. And here's an individual patient where we interfered with naming but not reading, reading but not naming, and then both of them up here in the supramarginal gyrus. And then this is 55 patients that we've pooled for that same thing. The filled ones here, sites where we made a proportion of sites that we interfered with both. The little dashed ones up here with just naming. The white open ones the white open ones just reading, so sentence reading. And as you can see down here in the superior temporal gyrus and middle gyrus, there are sites where you get a significant proportion of people where you can interfere with the reading as well. So the question is, do you map both? Well, some patients where reading is really important, we have, and sometimes you have to tailor your operation around them. Likewise with second languages, the same story holds. You find slightly different sites where you interfere with both. This happened to be a patient who taught English as a second language to Spanish speakers. Here's where his interference in English. Here was his interference in Spanish. No English changes, no Spanish changes, these other two sites. So in this patient, at least, where we map, completely separate. And then this was data that Tim Lucas put together on 22 patients, a variety of different languages, and nearly all of them had some sites where there was only a single language represented. Again, one has to make a decision about what functions to map based on what may be important for the patient, and yet how much you have to take out in order to control the problem you're dealing with. And this is data from a whole series of patients whom we looked at all these different functions in the individual subjects. And in this patient, here was the interference in the second language, second language was Greek. No interference in the first language naming. Here's a site where we interfered with the naming in the first language and not the second. Site where we interfered with sentence reading and not with any of the other things. A site where we interfered with the encoding phase of recent memory and nothing else. And the only things that seemed to overlap were this combination of oral facial motor movement and phoneme identification. So that, again, the general view being that there's a lot of representation of specific things that are individually variable for a variety of functions. You can make a sort of probability map here of that. Here are the sites that are involved with the oral facial movement, here with all movements and phoneme discrimination. The green, the sites with sequences of movements and phoneme discrimination. The yellow, the sites where we had interference with recent verbal memory encoding, and between them these sites of specialized areas of different aspects of reading and naming. So this is sort of a general model, but for individual subjects, there's still all this individual variability that you have to map out. Now you can map the non-dominant hemisphere. This is such a map. We've done this for investigational purposes. Here, a site of we're measuring mapping face perceptual matching of faces and figures. We're looking at the ability to label facial expressions, and then the memory function for faces involved. And the sites where we got interference in this particular patient, the square being the site where we interfered with direct matching, the star where we interfered only with the label put on the face expressions, and the filled ones where we interfered with the recent memory for faces with either stimulation during when the memory was stored or when the memory was retrieved. The problem, that mapping we don't routinely do simply because patients don't complain of problems of this kind after the surgery. Well, all of this, of course, is collaborative work. It's work done with both surgical collaborators, clinical physiology collaborators, and neuropsychologists who provide many of the measures that we have used. So in that sense, it's the quintessential example of this kind of interdisciplinary collaboration. I want to thank you.
Professor Ojemann, can you please comment on stimulation of deep areas of the brain, such as a capsule, and also the brainstem, whether this is being done, and how do you do it in relation to motor? I presume you may not be able to do language, but distinct motor or sensory areas.
Well, we use stimulation a lot to identify the capsule. For example, when you've got an intrinsic tumor that's grown into the temporal stem, and you've got the capsule on the medial posterior margin of it, the technique that I've used and Mitch then picked up was to take the stimulator, set it at the current level that evoked motor responses from cortex, and then simply use that as you planned your resection. And you would resect a little bit, stimulate, resect a little bit, stimulate, and then post-operatively we'd look back and see that we had stopped within a couple of millimeters, actually, of where the capsule.
So how do you decide or determine how much current?
What evokes motor movement from cortex?
So you have to have the basis. So let's say that I'm operating on the brainstem, and I don't have the motor area exposed. And I want to see if there's, yesterday I had a case, for instance, I was trying to see if I can evoke either motor response or facial motor response from particular areas.
From face. I don't have any experience with that, and I really can't tell you what kind of current level you'd need to use. My guess would be that it's smaller, but I don't know that. That's actually another area of controversy that I didn't get into, and that is the San Francisco group believes that you don't have to have positive responses if you're mapping. If it's all negative, they're happy. And they've published data on this, which is really quite convincing. That I've always been very uncomfortable with that. I want to know that my current is adequate to at least interfere with the language function somewhere. So that I've always wanted a positive response, and then that current is the one that I'll use for mapping.
Are there any cases? You want to hold on a second? You want to address the brainstem thing, or what were you raising your hand?
Oh no, I was a totally different question. No, the brainstem. Oh yeah.
No, just a follow-up. Are there any cases, for instance, a person who's had a temporal lobectomy already, and you went back, and any patients, awake patients, where brainstem has been stimulated, or no? Because that would be readily accessible, for instance.
No, you certainly could. You could stimulate the peduncle, yeah.
Yeah, that's what I mean.
You know, you're sort of, I've certainly followed the internal capsule down into the peduncle and stimulated the peduncle. Mm-hmm. And there I've just been just like motor mapping in the white matter. But other than that, I have not. I have a few cases where I have actually evoked visual responses from stimulation in the temporal white matter, but that's pretty rare. Presumably, it's the optic radiations that you've activated.
All right, Bob Hebner and then Nino.
Thank you for a wonderful talk and for putting all this together. Your observations of individual variability in the size and location of the language areas really fit with what's been found in developmental neurobiology about shifts in the cortical area distribution. And I was really intrigued that you found those patients who seem to lack either an anterior or a posterior area. And so I have two questions. One is it possible that those areas were buried in the sulci, Sylvian fissure? And the second question is, were there consistent patterns in shifts between individuals? In other words, if someone had a posterior shift or posteriorly located anterior area, would their posterior area also shift posteriorly?
The answer to your first question is that I don't know, but I can infer something. I know that the surface stimulation has told me what I can resect straight down, as long as I don't undercut it. Which means that although there's a lot of pericortex that goes with that resection, there wasn't in that area something crucial for language. Mm-hmm. Mm-hmm. So that's as far as I can go, because I don't, of course, have extensive mapping of that buried cortex. Okay. I have simulated the banks of the gyri once they're exposed by having resected the adjacent gyrus. And I have often had this phenomenon of a surface site where you get interference, and you just move your electrode just around the corner, and nothing happens. Mm. So there's something different about the crowns of gyri. And I raised this issue with Arnie Scheibel once, who knows a great deal about cortical anatomy at a microscopic level. And he said that there is a difference in the patterns of the neurons on the crowns of the gyri versus the depths of the sulci. That the spread of the basal dendrites and the ratio between that and the surface dendrites is different for those neurons. So it isn't just a matter of suddenly the brain was just accidentally folded. You took a perfectly decent brain and then scrunched it up to get it in the head. It's more a matter of there's something different in the development about those different areas.
Yes. Yes. And so, what about the shifts?
Yeah. No, I don't think I've seen any consistent pattern that way. We've had the patients with the small group of patients where we couldn't find frontal sites have had perfectly decent posterior sites that are in sort of ordinary locations. And those who have posterior sites in ordinary locations and we can't find frontal, they're in ordinary locations. So everything, it's sort of just something missing.
Nino?
Again, thank you so much for the wonderful lecture. Are there attempts to also map higher brain functions, like either prefrontal cortex, decision making,
You mean like moral and religious?
I think that's what it's going to be. No, Donald Trump will not be mapped. Is that what you were asking?
I can't resist at this point. I came across a paper yesterday, or a couple days ago, that I think was in one of the Frontiers journals, in which they had used transcranial magnetic stimulation to modify people's political leanings.
Is that legal? That's like waterboarding.
There you are.
Yeah. Dan Silvergeld's hiding there.
Yeah, I just have a question. So I agree with you. I don't like Mitch's idea that you get negative results and you act on that because absence of evidence is not evidence of absence. But in your paper with 117
that was very
patients,
slick, Dan.
That was.
Yeah, I like
what?
that. I like that. That was very slick.
So, but in your paper with 117 patients, a little over a third of the patients had more than one temporal lobe language area.
Right.
So you go through and you map the temporal lobe and you're pretty happy because you found an area and you say this is positive results.
Right.
But maybe if you go up a couple milliamps in your current, you might find a second area because we know you go through and you don't find anything, you turn it up a little bit even though it's getting closer to after discharges and finally you find it.
Right.
So you kind of struggle a little.
Right.
But what if you had struggled a little more and found a second one? So you basically, you may have absence of evidence for that second or third area, and you may actually be playing Mitch's game inadvertently. Well,
early on, when we were first putting together these cases back in the 70s, we had a group of cases where we sort of thought we had a graded margin around these the sites where we got stimulation interference, as though there was not a sharp border. In some of the patients, we seemed to have a really sharp border. But in a group of them, there seemed to be sort of a penumbra around a site where you got highly repeated errors, where you could get a little bit of effect, but not very much. And it may well be that this is what we get with stimulation. We set a current, we get the sites that are crucial, and we give them a margin. And that's our safety zone. And if we stimulate it at a higher current, maybe we get some effects from that.
Andrew, and then, Randy, I'm sorry, Randy was next, and then Andrew. Randy?
George, I just have a sort of biophysics question. We know that given stimulation
the way you set up the stimulator, the way you stimulate the local microenvironment, orientation of neurons, within the current density that you generate, you can activate and block neurons with the stimulation. And I'm wondering that mix, how you can tell exactly what you're doing and how movement might not just vary that interaction.
Well, I've looked at that a little bit. We use bipolar stimulation. And how you orient, does it change if you alter the orientation of the electrode a little bit? And the answer seems to be not very much.
How did you come up with the distance? How did you come up with the distance between the bipolar?
Oh, that's been totally arbitrary. A
Okay.
whole bunch of things on this are totally arbitrary.
Okay.
So using 60 hertz, which is what we always use, is totally arbitrary.
Oh, damn, I thought that...
Anything from 30 hertz up is probably enough.
Okay.
You get a different kind of effects if you stimulate at a much lower frequency.
And the inter-probe distance was...
It was 5 millimeters. We just picked that. Now, when we stick in grids, we don't generally have them that fine. They're generally a centimeter apart.
Right.
And we stimulate through them perfectly happily, although the effects are, for a number of reasons, a little more fuzzy.
But you're considering this to be the stimulation to be stimulating neurons or blocking neurons or a little bit of both?
I personally think that what it does is it produces depolarization blockade of neurons firing and of the afferent input, the ascending axons, end of the axons. And there's experimental evidence for both of those. But I don't think anyone knows for sure exactly what happens when we put in stimulating current. We know behaviorally what it does. We know that if you put the current same current on a patient who's just lying there quietly, they don't feel anything, they don't experience anything. You make them undertake a task, it acts just like a lesion. It reflects the effect of a lesion. It does that for deep brain stimulation. It does that reflecting the same effect that we got with thalamotomies. It does that for cortical resections.
Andrew Coe.
Two things. One, just to follow up for Dr. Chestnut, I think from DBS, we kind of tend to think that a lot of these effects are actually axonal. Let's go along with what you were saying, it's not necessarily a neuronal effect, but I mean, there's neuronal effects, but they tend to be kind of mixed with DBS, so you'll see some cells fire more, you'll see some fire less. You can look at what happens to axons, that's where you see the effect. But Dr. Ojemann, I was wondering if you could comment on just something phenomenologically that I've noticed that in terms of mapping cortex, subtemporal sites, if there's some evidence that you've noticed just from our work with the lasers, we've just had a few people where you do your dominant side of the campus. If your laser's lower and you seem to get a little bit of pericampus, people tend to have what seems more like an anomia rather than a memory problem.
Is this the Luder's effect?
Yes, this is the Cleveland Clinic effect.
Yes.
Okay. Well, we have had patients where we evoked naming changes from strip electrodes placed underneath the temporal lobe and in portions of I don't know, it was perihippocampal gyrus, but it was a little bit further lateral than that, probably a portion of the medial fusal horn. But I have undertaken a very large number of temporal lobes resections where I never bothered to do that mapping, and certainly took out all that, and haven't seen much in the post-operative period. I know the Cleveland Clinic people think there is a subtle change, and maybe there is, but I just haven't seen that. And we just haven't routinely mapped that, except occasionally when we sort of interested.
Yeah, this, George, I can say for the entire audience, this was inspirational and fantastic. Thank you very much. In Jeff's loss. So
He doesn't get to see, he's going to miss the thing by one day.
well, we got it on video, putting on the...
Wonderful.
That's true. Total 6.